later will be posted on our website. Just housekeeping issue before we really get into the meat of the presentations. Everyone is joining us via your computer. So those of you who may be joining us on the phone, lines are muted. So there is the only way that you may type or may ask your questions is to type your question in the Q&A box with your computer screen, and you can type questions in throughout the presentation, and we'll be answering questions at the end of the those presentations. I also just want to let you know that we are unable to answer specific questions about your health insurance plan or any sort of specific situation that you have a question about. But feel free to reach out to any of us after the presentation, and we would be happy to help you with that. Is on the phone any trouble, or if anyone can hear me and is having trouble seeing the actual presentations, please email Amy Martin at amartin@myeloma.org or call her at 617-870-4870, and she will email you the slides. So we would also be happy to email everyone who wants the slides. We can email them to you as well. It will be recorded and posted on our website for future viewing. Before I introduce our guest speaker, I just want to remind everyone that our main focus of this webinar is enrollment in the health insurance marketplaces. And the marketplaces are specifically designed for those who are currently uninsured or underinsured, small businesses, and those that are in the individual market. If you have employer-sponsored coverage or Medicare, you do need to enroll through a health insurance marketplace. We would never, at the end, second presentation, be going over resources that all cancer patients can use, both enrolling and in the marketplace, and also just when for a new insurance plan. Now, pleasure to introduce our guest speaker tonight, Mark Hobroch, who joins us from Patient Services Incorporated. Mark has spent over 2 decades expanding access to care for those with high-cost medical conditions. He started out as the Institutional Reimbursement Manager for Wyoming Medicaid, the reimbursement program for the world's largest manufacturer of cochlear devices that help the deaf restore hearing, and direct healthcare financing and advocacy efforts for the American Speech Language Association and Health Industry Distributors Association. Mark went to law school mid-career, where he represented low-income clients in the University of Denver's Disability Clinic, and a similar role for the Access Program, which was gifted to Patient Services Incorporated in 2009, and he has since served as a Government Relations Associate for PSI, which is a nonprofit charitable organization that provides premium and co-payment assistance for over 2,000 rare and chronic disorders. Earned a Master of Public Administration from the George Washington University and a Bachelor in Economics from Rutgers University. Mark, thank you for joining us, and I will turn things over to you to get started.
Good evening to everybody. I've been invited tonight to help explain how the new health insurance marketplaces work under the Affordable Care Act. However, they're not a new idea at all. Next slide, please. The marketplaces have been around for quite a while. They are basically a market-based solution that allows private plans to broaden their risk pools in order to provide more affordable coverage to everybody that has pre-existing conditions or a costly medical condition. It was intended the individual market where coverage was either unavailable or unaffordable for a large number of people with any type of condition like cancer or hemophilia. It basically pools the insurance risk, which is the advantage for the insurers, but for the consumers, it creates a level of price transparency, and that allows you to be able to shop around for the first time and make apples comparisons among standardized plans. Some examples of marketing around for a while are the Health Benefit Plan, Medicaid, and Massachusetts Health Connector, upon which the Affordable Care Act was based. Next slide, please. Affordable Care Act marketplaces have one obvious difference, which is that any plan that participates has to comply with all of the requirements of the Affordable Care Act, especially the new consumer protections you've heard so much about, like guaranteed issue and minimum essential benefits. Any grandfathered plans within the marketplace. Certain plans will be allowed to continue as they were before if they were in existence before the ACA. If they were in existence after the ACA was passed, or they've made any substantial change since then, they no longer be grandfathered, and whether they're in or out of the marketplace, they have to comply with all the new rules. Approved plans in the marketplace are called qualified health plans, and they have on their premiums that you're probably aware of. Basically, only vary what you have to pay by the type of plan, how big it is, how old you are, where you live, even within a state, and whether you use tobacco or not. They determine whether you're eligible for the premium assistance that the new law provides. It will also automatically enroll you in any public health care plans, such as Medicare or Medicaid, that you may qualify for. That people will notice right away is that the provider networks within the marketplace will tend to be more narrow than you'll find outside of the marketplace. That was especially during the first year to make sure that plans would still be affordable when you had huge numbers of people transitioning into the marketplace that were previously uninsured or only able to be covered through high-risk pools for people with pre-existing conditions. Next slide. There's two types of marketplaces. When we say marketplace, there's a small business marketplace. I won't talk much about that one tonight, just so you're aware. It's somewhere that if you have a company that has less than 50 employees, they can purchase healthcare plans for their workers. Individual marketplace, which is the one that will affect most consumers, is essentially everybody. There is a bit of a misnomer that even the Secretary of Health and Human Services misstated to Congress a few weeks ago, which is that it's only available to certain people that insurance through their employer that are unaffordable. If you have insurance through your employer, that insurance costs 7.5% of your income, you have coverage in the marketplace. However, what it does do is it excludes you from receiving of premium tax credits or cost-sharing subsidies for any public health insurance program, Medicare or Medicaid, and you have to be a citizen or lawful resident and not incarcerated. Next slide, please. Just a quick visual so you can get how it works. You have the different category of people that are all funneled through the marketplace, which used to be called exchanges, and then you have a standard set of benefits that several carriers provide. Next slide, please. Three choices that they get when deciding how to set up their marketplace. About 15 states and D.C. chose to retain control over all of the functions of the marketplace, and that included the most costly part, which was the web portal. Decided that they will be a state marketplace eventually, but they just couldn't get up to speed in time the October 1st deadline for open enrollment. Those states are among the 36 states that are being federally controlled. The 29 have defaulted to full federal control, at least for now. There are 7 states among that group that HHS has allowed to carry on some plan management functions like reviewing rates or certifying plans. Next slide, please. All the states that are under federal control, SPM indicates the partnership states. Idaho, one of the asterisks, a state that decided they couldn't get up to speed, but instead of being a partnership, they wanted full federal control for the first year. The other 3 stars, the other 3 asterisks are interesting because they're kind of a hybrid model, at least for year 1. They've decided to control their small business marketplace, but leave the individual marketplace fully to federal control. Next. States could choose from. The first was the active purchaser model, which Massachusetts has done since 2007. However, this model proved to not be very politically palatable, so only 3 other states followed suit: California, Rhode Island, and Vermont. Basically lowers premiums by allowing the Board for the Exchange to negotiate with insurers, and they can hardball them and exclude insurers that won't lower their premiums even if they otherwise meet standards, all the minimum standards of the marketplace. Being not palatable, several states decided to go instead with what's called a market organizer, where they could limit the number of qualified health plans that an insurer offer. The rates, including all of the federally controlled states, have called the Clearinghouse model, and that is where all insurers that meet minimum standards must participate. Next slide, please. Before the marketplace plans are standardized, there are basically 4 plans that marketplace insurers are allowed to offer to consumers. The highest level plan, the Platinum plan, it pays 90% of the total average cost for covered benefits, which is also called actuarial value. It has premiums, however, it also has the lowest cost sharing. So it's a real trade-off of individual needs. Go down in the metal tiers from gold to silver to bronze. Each plan will pay us. Each plan has a premium. You get the bronze plan with the lowest premium. You also have the highest cost sharing, which can be up to a $5,000 deductible. Only available is a catastrophic or limited benefit plan, which is for young adults under age 30. I mentioned the non-grandfathered plans outside the marketplace. They must also follow these tier levels starting in 2014. Next, please. There are 10 potential benefits that all individual and small plans, whether they're in the marketplace or not, must cover unless they're grandfathered. These include hospitalization, care, emergency care, rehabilitative services. They focused on prescription drugs, which is the one we certainly get the most questions about at PSI. However, just because prescription drugs are one of the 10 benefits that must be covered does not necessarily mean that your drug will be covered by a qualified health plan within your state. The reason for that is that HHS left the definition of these categories up to the state, and cases defaulted to their largest small group plan. So typically whatever drugs are covered under the largest small group plan in your state is probably going to be what is covered within your marketplace. Each state has a list of covered medicines, so you will not have the same level of drugs in one category or class that a plan offers in one state versus what the same plan offers in another state. Because of that, it's very important to check the formulary for every plan before you select coverage. This is not always available on the website, especially not the federal portal, but even on some of the state portals, so you may need to contact the plan directly. You can go to the website once you've identified a plan you're interested in and see if the drugs that you need are on that formulary. The new opportunity for you to appeal if your drug is not. Next. Most in or out of the marketplace typically follow these 4 tiers of prescription drugs. The lowest tier 1 for generics will have the lowest cost sharing, going up to tier 4, which is for specialty drugs for the highest cost conditions. Now, these specialty drugs often come with a coinsurance, which means that you have to pay a percent of the total cost of the drug. Obviously, for a drug that costs $100,000 or more, this can be an amount that makes it prohibitive and prevents many consumers from having access to that drug. The type of drugs that you often see in this specialty tier are the biologics and the oral chemotherapy medications that we at PSI deal with quite often. Next slide, please. And, one of our #1 issues over the past several years, the Affordable Care Act doesn't impose new out-of-pocket limits, which is a very important step, but it does not entirely eliminate the problem because consumers still have a huge upfront cost that they will have to pay until they hit this out-of-pocket limit. See, the lower plans in the marketplaces still heavily on the specialty tier coinsurance. Almost 90% of the bronze plans, and even when you move up to the silver plans, they charge a level of co-payments, $270 on average for Tier 4 silver plans. That means buying both bronze and silver plans together, Tier 3 or 4 drugs, a cost sharing of the cost of the drug. So a very prohibitive pocket cap. Next. Credits under the law are available for those earning 100 to 400% of the poverty level. You can see roughly what that translates to, up to about $46,000 for an individual and $94,000 for a family. So generous, more than the Massachusetts Health Connector, which only went up to 300%. However, the key again is that you cannot be eligible for a full employer coverage, and that goes up to 9.5% of income. However, that income is defined as your household income, but the cost to determine the 9.5% is defined only on individual coverage, not on family coverage. So that will exclude many people that family coverage and should be over that amount, but are not because only individual coverage is being counted. The tax credits can be used to purchase coverage for dependents. However, once again, there is a barrier because dependents cannot receive tax credits if the subscriber is ineligible for the tax credit itself because his or her coverage is affordable. Where many plans charge an amount for the subscriber than they do for dependent coverage. Dependent coverage is often higher. However, even if the dependent coverage would go over 9.5% of your income, if the coverage for the subscriber is under that, the dependents are ineligible for the tax credits as well. Next slide, please. Tax calculated based on the premium for the second lowest cost silver plan. This gets because one of the top questions we're asked by consumers at PSI is, well, what happens if you want a level plan? Many high-cost conditions. Platinum plan is often the best value for them with their condition, and so make sure that they can afford that plan with the tax credit. However, the tax credit itself will not increase if you go up to a gold or a platinum plan. That the amount of the credit is only the difference between the premium and the what's called an affordability cap. Now, sliding scale, it goes down to 2% of income for those at the lowest end of the eligibility range for tax credits, 100 to 133%, and then to the 9.5% that I mentioned for those earning up to 400%. Will increase years. Here's how it might work. If you have an individual who's about 45 years old and earning right in the middle of that range, about 250% of poverty, $20,000, and they purchase a plan, a first-class silver plan that has a premium of about $5,700, they will have an affordability cap of 8.05%, about $2,300. So subtract the amount of their affordability cap, the 2013, from the amount of their premium, the $5,733, you get a of $3,420 that would automatically be sent to the insurer. However, this individual decides to go up to the gold, she's going to, which is in this hypothetical example, $2,000. So then the amount that she has to pay, instead of being $2,313, now $4,313. Next slide, please. When they're accepting the tax credit, the one that is going to be popular is certainly the advanceable tax credit, which means that they get the benefit of it at the time of purchase. However, there is a significant risk in doing this, which is that if your income changes during the year, especially if it goes above 400% and you're no longer eligible for a tax credit, you're going to have an overpayment that you're going to be required to repay at tax time. Now, Congress envisions this being overly burdensome. Remember, consider caps on it that have been adjusted a couple times since the law passed. Right at $300 for an individual and $600 for families, and as you can see, it goes up to $1,250 and $2,500 for those at the top end of the eligibility scale. As I mentioned, there's no payment cap at all if you go over 400%. So if you're substantially during the year, you could still have a significant amount to repay at tax time. The only way to avoid that is to make the tax credit refundable. You have to pay the entire amount up front, and that's something a lot of patients can't do. But if you can do it, the entire credit will be refunded to you at tax time, regardless if the amount you owe in taxes is less than that, or even if you have no tax liability, you will get the entire amount of the tax credit. Next slide. There are sharing subsidies available under the law for those earning only up to 250% of poverty, as opposed to the 400% for the tax credits. The biggest, though, and the one that causes the most confusion, is that cost subsidies are linked only to the silver plan. You don't have the option anymore to go up to a gold or platinum plan like you did with the premium tax credits. So what this is, you're going to have to be stuck with the silver plan and make sure that's what you want. However, it will reduce your deductibles, coinsurance, and copayments, and as you can see, it's also on a sliding scale, so it goes to only 6% of covered health care cost for those at the lowest end of that scale, 100%, and for those 250% of poverty, they will pay, it scales up to 27%, so they'll only have to pay 27% of their covered health care cost. Slide, please. Pocket caps are one of the key for people with high-cost conditions. Every law has its pluses and minuses. This was certainly a plus because starting in 2014, all individual and small group plans, whether they're marketplace or non-marketplace, are going to have to comply with these limits. The maximum will be whatever the federal health savings account limit is for that year. And for next year, that's $6,350 for individuals and $12,700 for families. Now, people are confused and don't realize that premiums do not count towards this out-of-pocket limit. We're just talking about deductibles, coinsurance, copayments when you consider your limit. However, it's very important to ensure that you examine plans that might be available to you in the marketplace, because those in the higher tier, gold and platinum, can lower out-of-pocket limits significantly lower. Your pocket limits go down towards $2,000 in the very highest level marketplace plan. 2014, you really need to check and make sure whether there is a combined limit or two separate plans with multiple administrators, those where a different administrator over the prescription drug benefit versus the medical benefit, to have two different out-of-pocket limits, so you can wind up paying double what you expected if you enroll in a plan that has separate limits for next year. Next slide, please. Those for ACA subsidies appear still that groups like ours, third-party premium assistance groups like ours, can continue to assist with marketplace plans, because HHS a couple of weeks ago defined the health plans in the marketplace as private plans and not public plans like Medicare or Medicaid. Later, they then issued a memo that appears to practice at least for hospitals. So this is still a bit of a fluid situation. At this point, it certainly appears like they're going to go with the private plan definition, which is for people groups like ours for premium assistance. If you're earning less than 100%, if you are that is not expanding Medicaid, next now it looks like there will be about 24 of those. You will not be eligible for any of the premium tax credits or the cost subsidies because they only go down to those earning 100%. So those are groups that certainly ACA is going to have to continue assisting in the opt-out states. However, CMS did make them exempt from any individual mandate penalties. Next, please. That you see in your marketplace will look a lot like the competition that you currently see in the individual market. Those states that have healthy individual markets have healthy individual marketplaces under the ACA. Those states that are dominated by one or two insurers will have marketplaces dominated by only one and two insurers. I've listed a couple of these here. In particular, New Hampshire for 2014 will only have one insurer in their marketplace, Anthem Blue Cross. Now, plans average 53 qualified health plan options within all of the 30 states that are under federal appears a very healthy level of competition, but when you look at it closely, it varies quite a bit to state. It goes down to, as you can see, only 7 options, consumers in Alabama, up to well over 100 for those in Florida or Arizona. Certain studies have found market participation by up to 25 or 35%. Next slide. As you can map, that really depends upon where you live, especially within a state. The groups didn't have data for this slide because those are your state-based marketplaces. The light blue shaded are where you have only a handful of plan options, and these are your states like, as I mentioned, Wyoming, New Hampshire, and Maine. States, Florida, Utah, parts of Wisconsin, states that have a very high level of marketplace participation and competition. Next slide, please. What's so important is because the level of competition directly translates to what you will pay in your state. State Wisconsin, where variance can change by over 100%. If you live, you're going to pay far less than if you live in Southwest Georgia, where there is an insurer, Blue Cross, that will be competing, at least for the time being. The extreme example is in a county in Wisconsin, where you have monthly silver premiums that go up to or go over $1,000 a month, even though the national average is only around $328. HHS studies showing that premiums are an average 31 to 35% higher in those counties where there are less than 10 options. And those premiums go even higher in 20% of counties where there's only one insurer and the 33% of counties where there's only two. Next slide, please. Premium currently comes out to $328. That's before tax credits, and that's below the amount that was initially projected. The average bronze plan is slightly less than that, $249, and you can see how it declines depending on your age and whether you're getting tax credits. The lowest premiums were in the state of Minnesota. Tennessee wasn't far behind, and again, because of the lack of competition, Wyoming, which only have 2 participating insurers each, had the highest premium, $516 and $474. And see how those go up for a family of 4, all the way to $1,200, more than $1,200 in Wyoming. Next slide, please. Platinum plans often provide the best value for consumers with type of a high-cost condition. You have the out-of-pocket caps that can be lower than the maximum that's now allowed. You have broader coverage, and even though you have higher premiums, you have much lower cost sharing than you see in the bronze and silver plans. Consumers can also typically avoid specialty tier coinsurance if they go with the platinum or gold coverage. California especially has no deductible on gold. You go up to a $5,000 deductible. However, some coverage is not available in many states, or many federal marketplaces especially. There's only a couple states that mandate at California, Massachusetts, New York, and Vermont. Next slide, please. That gives you a visual of that. You can see all white areas are federal marketplace states where there's no platinum coverage available at all. In blue, you just have a handful of plan options, and again, Florida, Arizona, and parts of Wisconsin are the only parts of the country with a significant number of platinum plans available. Next slide, please. Now, by a standard, the initial rollout of the federal website for the marketplaces were a disaster. Were non-functional for the first weeks after October 1st, and had a wide effect on all states, whether they were federal or state-based. Because it's called the Federal Data Hub that all states have to use to access the federal agency data needed to determine eligibility for the marketplace, for Medicaid, and for the premium tax credits. However, state marketplaces are doing better than their federal counterparts. Kentucky, Connecticut, Washington, those are examples of states that have beat projections, but you have several states that are having major problems. Oregon, in particular, will not have any online enrollment capacity now until at least December 15th. Federal things are improving, however, very slowly. Process 17,000 errors, however, they still have downs when they have to handle more than 20 or 30,000 simultaneous users. The goal 80% of the applicants can enroll through the federal web by November 30th, next week. That appears doubtful at this point. This week they acknowledge that they still have 30 to 40% of the information technology infrastructure to build, transmit payment data once coverage starts on January 1st. Next slide, please. A little over 100,000 people that were able to enroll nationwide. States were able to enroll 4 times more than federal marketplaces were. The only place where there was really any success was in enrolling people eligible for Medicaid. Nearly 400,000 eligible either for Medicaid or SHIP. And in some states that had a big difference. Any online enrollment at all was able to reduce their uninsured rate by 10% just because of that. California is the one state that, after a few initial problems, they're far away beating everybody else. They're more than double now what the federally operated marketplaces enrolled in October. HS is quick to emphasize that despite these very low numbers, they're still ahead of the initial first-month enrollment in the Massachusetts Health Connector. The trend with these marketplaces always is that human nature, what it is, we don't tend to enroll until there's a deadline. I don't tend to actually pay our premiums, so you're likely to see at least a jump in enrollment as we approach December 15th, so people can be sure to have coverage January 1st and after the March 31st open enrollment period. Next, please. That caused the biggest backlog initially in the federal marketplace. The CMS made a flawed decision, as it turned out, to not allow people to anonymously shop for premium information or any type of benefit details like you can on Amazon.com or Southwest.com. And because these online accounts that were required to verify your identity just not functional, that just created basically a firewall to get into the website over the first week or two. They have adjustments to that. You can now view some plan information anonymously, but you'll have to create the online account in order for it to be tailored to your age and family size and where you live. The best at this is Connecticut. They require only 4 steps to be able to get to that point. Ireland and Minnesota also score very well. However, the federal website requires something like 26 steps to be able to do that. Next slide, please. I'm sure you've heard quite a bit about in recent weeks. There have been over 5 million plans that were canceled because they wouldn't meet ACA standards after January 1st. They would not be grandfathered once the new consumer protections went into effect. This is always a problem in the individual market. They're only on one-year contracts. However, it was a particularly problematic issue this year because of the web portal failures. Very, very difficult for these patients to be able to transition from the plans into a more comprehensive marketplace plan. And as a result of that, HHS really had little choice but to allow insurance commissioners decide whether in their state they were going to allow these non-grandfathered plans to continue or actually re-enroll people in plans that were canceled. Insurers have been very reluctant. Insurance commissioners have been very reluctant to do this. Insurance commissioners understand. Insurers are very understandably concerned about that they set their premiums for 2014 based upon an assumption that a certain number of young and healthy individuals would come into the risk pool for the marketplaces. Then you have a situation where you could have the rate shock that hasn't materialized yet, but what will happen if these marketplaces turn into what are essentially high-risk pools for more costly consumers. It also impacts the high-risk pools who now have to decide whether to extend coverage into 25 had already closed or decided to close December 31st or the first few months. And the federal high-risk pools will have to transition by December 15th. CMS has not announced any decision yet on delaying the cancel individuals. Apply for the marketplace, obviously healthcare.gov. You can also call the 800 number for any assistance in applying on healthcare.gov or by paper person. You also have the going directly in your plan directly from the insurer through an insurance broker or an agent. You'll automatically be referred to your correct marketplace. If you qualify, you'll be referred to Medicaid or other public health program. Qualify. The whole system was to have a simplified application that made it a lot easier for the consumer as long as it worked. Slide, please. So we commonly give to consumers, and number one of those is certainly always important, and they're always the first thing that anybody should look at, but don't overemphasize them versus the total value of the plan to you, especially with the new out-of-pocket caps. It's also important to review all the plan levels that are available to you. Don't automatically assume that a platinum plan will not be affordable to you. Don't automatically assume that the only thing that will be of value for you is a platinum plan. There are several silver plans in Florida, in fact, that have no coinsurance, even though some have very high coinsurance. It pays to check all the plan options out there. Before, we'll need to go directly to an insurer's website to check for a lot of information that is still missing, even on the state marketplace sites. These include things like the directories and the formularies I mentioned. And something else very important is to try healthcare.gov at different times of day. Don't, if you get frustrated that you can't get in over several hours one evening. I know in the third week, I was able to go through from beginning to end in half an hour and then went on again last night and couldn't get in at all. But when I tried this morning, it went through with no problem. So there's difficulty at peak volume, and so a day you are certainly going to have different experiences. Next slide, please. Real quick here so I can wrap up is that the plans in the marketplace accept different payment methods from people that have bank accounts. So it's not just credit cards. You can check, a prepaid debit card, bank transfers, all of the options listed here. Your plan premiums by March 31st, or else the individual penalties, no insurance for 3 consecutive months, will start to kick in. Next slide, please. I just wanted you to make sure that there are navigators, other forms of assisters that are available to help you through the entire process. There's a full list of them available on healthcare.gov. You can just your zip code or call the 800 number I listed. Participating in this process, when they decided to do that is because they have something called certified application counselors that can just assist specific disease communities. So at healthcare.gov, you may be able to find one that is very familiar with your particular condition. Slide, please. Presentation. I'm certainly happy to take any questions. I hope that I've clarified it more than confused it, but if there's anything that is still confusing, please do let me know.
Mark, and we will be taking or answering questions at the end of this next presentation. But thank you much, and Mark will be around to answer all of your questions regarding his presentation. And just to remember, we're happy to share the slides with you, and this is also being recorded, and so it will be posted on our website either or early next week. Wanted to give just a little update on what the IMF Advocacy Team has been working on around ACA implementation, and Mark did an excellent job. The insurance marketplaces and also making us aware of some of the issues within the marketplaces that the IMF has been monitoring. So just quickly wanted to introduce my team. I'm, again, Megan Busby, the Director of U.S. Advocacy, and I am actually joined on the phone tonight, although you have not heard any of them speak, by Amy Martin, our Grassroots Liaison, Zena Carey, our National State Affairs Consultant, and Jennifer Lieb and Joanna Gray, who are with CRD Associates in D.C. and act as our government affairs consultants. Job of including these things on the things to keep in mind, but I just wanted to emphasize them even more. One thing that we've really noticed is that the transparency of the qualified health plans is an area of concern. It's difficult for patients and consumers to find information to make an informed decision, and Mark pointed out some specific that with the network providers, making sure they're in network, also the formaries, finding out if your Revlimid is covered and at what cost it's covered. He also talked about, not choosing a plan based solely on premium costs. That is an important factor to consider. But as he mentioned, the tiers will have, or certain plans with the middle tier may have a lower premium cost, but the cost can be very high. So pay attention to your cost sharing for services and drugs. Again, make sure your doctors are in network. And also just one thing that we've been hearing is that some plans are offering integrated deductibles, then having a separate deductible for your drugs and your services. They're combining them until patients are seeing benefits paid. So they're having to reach higher deductibles. And these things that the IMF is monitoring. And some of the other things that we're doing is our coalition that we formed in July of 2012 called State Patients Equal Access Coalition, or SPEAK, how we refer to it, has recently formed an ACA implementation working group that's coming up with solutions to some of those issues we just talked about, specifically the transparency issue and the cost sharing and prescription drug coverage issues within the marketplaces. The working group is made up of patient groups, provider groups, and industry partners. We also work with the Leadership Council, which is another coalition, cancer coalition based in D.C. We are also very involved with PHMA and other groups that are monitoring and offering the IMF an opportunity to weigh in on these areas of concern. We've also recently created a multiple myeloma insurance questionnaire, and this is a really helpful resource for those shopping for insurance, whether they're shopping for a plan within the marketplace, whether looking at Medicare plans to purchase, and whether they're looking for a private plan, including employer-sponsored coverage. So when basically anyone is looking to change insurance or purchase a new plan, they can use this questionnaire to help navigate that process. The question is found on our website, and I will show you where to find it. I just drew the questions, but in a much shorter form. So basically, this is just a in front of you when looking at the different plans to make sure that all of these things are covered, like your blood and urine and serum protein tests or the bone aspirations, imaging tests, and then also, in addition to that, finding out what are the share of your costs of those benefits, and then are there any annual or lifetime limits on the number of tests or services, specifically blood and urine serum protein tests, the bone aspirations and biopsies, imaging tests, and radiotherapy. Are there annual or lifetime limits on the number of those tests? So I encourage you to visit our website, which I am going to show you in just a couple slides, and print out this questionnaire and use it. You see fit when shopping for new insurance. And I know Mark also mentioned, and I can't emphasize this enough, that when you're shopping for an insurance plan, it's really important to contact that insurer directly and ask them these specific questions. You know, I want to know, is my doctor going to be in your network? And all of these questions did cover nutritional and lifestyle counseling. What are the costs associated, or are the costs associated with clinical trials covered in your plan? Do you cover stem cell transplants? You know, how many do you cover? What is my cost out of pocket going to be for that service? We create as part of a working group. Social support community is a wonderful partner of ours, and they headed up this initiative, and we were really happy to work with them. Unfortunately, they were unable to be on the call tonight, but they did share some slides that I'm able to show you. We similar to the multiple myeloma insurance questionnaire, but it's a little more for cancer. It's not specific to myeloma, but it does include all cancers, and it's an insurance checklist. It is specifically to be used when shopping for insurance within the marketplaces. You could also use it again for any of the other scenarios, you know, that you're getting a new plan. The website is cancerinsurancechecklist.org. There's also a link to this website on the IMF site, so it's very easy to find. Again, it was formed through a partnership of 19 cancer and advocacy organizations. So the cancer support community were just 2 of those organizations. In addition to that, there's 15 other supporting organizations that have that support this effort and have advertised that this insurance checklist exists, and they've posted it on their website and their social media sites. Again, use this checklist is if you have cancer, a history of cancer in your family, or you're at risk for cancer, and the waiting insurance plans, and discuss your insurance needs with your navigator or your marketplace representative. And so when discussing your cancer care needs with your healthcare provider, you can use this as well. And we're hoping to translate it into Spanish very soon. Consists of 3 worksheets. The first worksheet is My Care, and that's a list of your providers. So you would fill out a list of your providers, your sites of care, and medication. So it's a really easy way for you to just write down everything that you're looking to get covered, and then when talking to these plans, find out if they will in fact be covered. The second worksheet is the Treatment and Health Services worksheet. And that's of common treatments and health services that people with cancer may need. And then, again, you can check and see if each service covered, whether a referral or pre-authorization is required, and then what the copay or co-insurance is. And limits or maximums, like we talked about with the myeloma insurance questionnaire. And the final worksheet is the My Costs which is it analyzes the costs associated with the plan, including the premium, the deductibles, the copays, and the coinsurance, any subsidies that you might be eligible for that Mark talked about. Of the partner organizations who worked to create this checklist. You'll see again that Cancer Support Community on here, the International Myeloma Foundation, and then a lot of our fond partners, Leukemia Lymphoma Society, Melanoma Research Foundation, National Coalition for Cancer Survivorship, the National Patient Advocate Foundation, and the list goes on. Many of these I'm sure you're very familiar with. Of those 15 supporting organizations who have, again, like I said, they support this effort. They were not part of the group that created that worksheet, but they all part of our group in that they are helping to get the word out that the cancer insurance checklist exists. And many have already received emails from different groups letting you know that it is now out there and live. Checklist helps people. Well, 15% of Americans are uninsured, and they'll be shopping for insurance for the first time on the marketplaces. Many of those have never had to evaluate health insurance plans because they've overinsured. Cancer is a very complex illness, and the decision-making about insurance is very complicated. Guide in evaluating the health plans so that you can understand what's covered and what your cost out of pocket is going to be associated with each plan you look at. So, it then will help you to get the best plan that will fit your needs. And then, as stated before, that it can help any evaluate insurance plans, even if you're not shopping for them within a marketplace. WebMF just created yesterday is a new web page on IMF site dedicated to the Affordable Care Act. It is you can reach it by visiting the website homepage and clicking on the Advocacy tab, or you can directly by visiting healthcarereform.myeloma.org. Different reasons there, we just this week created an Affordable Care Act Frequently Asked Questions document, which includes information on many commonly asked questions about the Affordable Care Act. It has a link to our Insurance Questionnaire. It has a link to the Cancer Insurance Checklist. It links to healthcare.gov, which Mark talked extensively about, which is where you go to apply or enroll in a marketplace. To the naggers that Mark mentioned, it has a direct link to that for an assistance where you can enter your zip code and get a list of all the people in your state or organizations in your state that can help you with enrollment. And it actually has much more, and it's a very so we plan on continuously adding to this page. Also, the new the ACA Frequently Asked Questions document is also a document, and we highly encourage any that you have to please reach out to one of us on the advocacy team so that we can add it to the document so that others can benefit from our response. Right now, I just want to very quickly, I know we're kind of coming up on the end of our time here, but I wanted to just show you and to take you out and where you can find resources on our website. Visit www.myeloma.org, which I'm hoping you can see on your screen either now or in the next couple seconds. You will have Advocacy tab. There is a health form link, which, as I stated, is going to link you to our Frequently Asked Questions document, the Cancer Insurance Checklist, the Multiple Myeloma Insurance Questionnaire, healthcare.gov, enrollment assistance. You did mention that it depends on when you visit healthcare.gov to see if it's, if it's working. But it looks like it's working, so I hope that everyone can see this page. This is the homepage for healthcare.gov, where you will go to apply online. You can also apply by phone, as we said, and it will give you the phone number. It does allow you to, I was on it a couple of days ago, just kind of playing to see information you can get prior to putting in financial and personal information. So, see plans and prices before you fill out an application, and information in your area. You have to answer a few questions, but they're pretty simple. It's what kind of coverage you're looking for. So, I'm looking for coverage for myself or my family, and I'm looking for health coverage. And I don't live in Pennsylvania, but I live close to Pennsylvania. I live in Maryland, but Maryland is a state-based exchange, so just for illustration purposes, I'm choosing a federally run exchange just to show you what you can expect. You are asked to select your county within that state, and then who for the health coverage. So is it you and your spouse, or is it you, your spouse, and your children, just you and your children, or only your children? So you, your spouse, and children. And letting you know that these are the benefits required because of the essential health benefits. So, and also then some more information on the subsidies and lower costs that Mark was talking about. So you can see it takes a little bit of time to get through here to keep moving to the next page. But you can see that you are able to see some premium information here on, I think, this is 55 health plans that come up that are being offered on the federally run, exchange with the, you heard, this is a bronze plan. Here's a gold, silver. The silver plan, as Mark mentioned, are the plans that you must, in order to qualify for the cost of subsidies and the pre-help, you have to apply for silver plans. So this isn't, as I said, transparency here is sort of an issue because you can see this doesn't really tell you too much. We're hopeful that you are able to get more information when you actually apply. But see, just if you're looking for plans before, there's not a lot of information available. So again, just really encourage you to reach out to these individual plans and discuss your needs with them to make sure they're covered. And obviously encourage you to reach out to PI and other people that can help navigate through the process with you. Stop sharing my web browser. That really is the end of our presentation, and we are going to take time for questions. I don't know if we have time for this, but we were hoping to actually just take a quick poll. And open the poll. Feel free to poll. We're just kind of looking to see what health insurance you have, and if you're planning on purchasing a plan through Marketplace, and then just for fun, what your favorite season is. We can poll open, it remains open for minutes, and we can I would welcome you to type in your questions into the Q box on your screen. And Mark is here. I'm happy to answer any questions, and Jennifer and Joanna are also here to help us answer any questions.
I have one question about the marketplaces, and Mark, perhaps this would be a good one for you. The marketplaces include Medicare supplemental plans.
No, marketplaces are solely for private coverage. They are not for Medicaid, Medicaid, or any other public health care programs.
We have another question, Mark, I think is aimed at you. You talked a little bit about the difference in the number of plans being offered in different states. On whether there's a difference in participation or competition in states that have a federal-run marketplace versus a state-based one.
Competition roughly mirrors whatever the level of competition was in the state's individual marketplace, regardless of whether they're federal or state controlled. There really isn't a significant difference as far as the level of marketplace participation.
Yeah, I think you answered it.
Okay.
Thank you. Jen?
I don't see any other questions from people on the phone. So again, if you have any questions, please type them into your Q&A box. But since we're wrapping up, I'll ask both of our presenters, what would you say is the #1 tip for people who are exploring and shopping for plans in the marketplaces? Megan, if you want to go first.
Sure. I just think that the #1 tip I would have is to really do your due diligence to use the resources that the IMF has provided with the Myeloma Insurance Questionnaire and the Cancer Insurance Checklist, and out to the plans. And I'm sure it's what you want to do is spend an afternoon on the phone with these individual plans. But unfortunately, I just think that's probably the best advice I could give is to ensure that your needs are covered, because we wouldn't want any of our patients to select a plan that isn't going to provide affordable coverage for them.
That's about what the #1 recommendation you would have for those shopping for plans on the marketplace?
Before, what we certainly advise to our patients who call in is to make sure they consider the overall value of the plan and not just look at the premiums. The market cost or the out limits, particularly for patients with high-cost conditions, can be a huge difference in the value of the plan, even if the premium is higher than they previously paid.
Another question that just came in, and for participants, please keep them coming. We'll also add them to our ACA FAQ on the website. The next question is, how difficult do you expect that it would be to transfer coverage if you're moving to a different state?
And one that I think we need to do a little digging and get back to you, but just speculating, I think that if you purchased your insurance at the beginning of the year, Mark, correct me if I'm wrong, if you paid your entire premium, then you have that plan for the rest of the calendar year, correct?
Plan, but the difficulty comes in if you're transferring to another state. They define benefits differently, and so the term may differ. Each definition of essential health benefits, so what is covered in one plan, even for the same insurer, can differ by state.
Insurance, if you move from one state to another after you purchased it through the exchange?
I don't lose it, and it really depends. I guess something we have to research is which insurer you are purchased from, because Blue Cross is the only one that is participating in every single marketplace across the state, across the nation. To go from one insurer to a different insurer in a different market, that's a good question as far as exactly how that transition would take Marketplace.
Thank you.
I have time. Both Megan and Mark said that to get the real detailed information about what plans cover, you'll probably need to call them. So you have a sense that if insurance companies are willing to spend the time to answer the kinds of questions included on the checklist, or what what people with myeloma really need to know.
Missing from the federal web portal or some of the state portals can be found simply by going to the insurer's website, the formularies or the provider directories and provider networks. For more questions, they certainly have an incentive to people as possible as they can in these plans. So for them to spend the time to get you enrolled.
That I received, I don't know if anyone else, I guess someone was confused by your response about the Medicare supplemental plan because they are offered by private companies, and I just wondered if you could.
Offered by private companies are considered public plans, offered in the marketplaces.
To clarify, if someone has Medicare, any interaction at all with the marketplaces?
No. You purchase a marketplace plan if you have Medicare, Medicaid, or any other public health care program.
And what if a person spends time in 2 states? So someone like Snowbird who's here in 2 different states. Will the treatment need to be only provided in your home state?
I know, but that's. I'm sorry. I don't. Maybe should be addressed directly to the marketplace when you're applying. As far as what marketplace, I would assume it depends upon what is considered your permanent address.
Just add that I think that the question of if you need treatment out of your home state, I think brings up the concern about needing to access services not in network. Whether you need to see a myeloma specialist who's not in your network, what happens then? And so I would just encourage folks that when they're evaluating plans to look at the out-of-network benefits. These plans will have different rules regarding whether you're allowed to see doctors not included in the network, and if you are, how much you'll have to pay for it. Unfortunately, I think it's another policy where it's going to really depend on your situation and the plans that you're evaluating.
Thank you. Questions. If you do have a question that was not answered, please again feel free to email any of us, and we will go through and questions. I don't know if I share the polling results with everyone. Thank you for filling that out. I don't know that it worked, that we're able to see it, but one kind of fun, interesting fact that nobody's favorite season is winter. So, I don't blame anyone for that one. Thank you all so much for joining us this evening, especially those of us here on the East Coast that, at this point now it's almost 8:15 at night, so that you have busy lives, and we really appreciate you joining us. And thank you, and have a great evening, and we will be in touch with some follow-up.